From the American Academy of Pediatrics.
When children are in pain, pediatricians can help, but the opioid epidemic has led to a decrease in prescriptions.
A new clinical practice guideline offers sound strategies for treating pain responsibly.
Opioids can and should be used. They're a mainstay of medical practice, but they don't always need to be used. And when we do use them, there are ways for us to do so safely.
Plus, new research shows how disabilities in parents can affect access to care for their kids.
From my perspective, I think one of the most important things that a healthcare provider could do is to take the time to really get to know these families, build that trusting relationship, ensure that there's some continuity of care.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about safely prescribing opioids to manage pain in children and teens.
Joanna, when I work in the hospital, I admit children with appendicitis, fractures, sickle cell crises, migraines, and a bunch of other painful conditions. And I'm always worried that when I prescribe opioids, I'm increasing their risk of developing opioid use disorder later on, but then I don't want them to experience unnecessary pain either.
David, you would be surprised about how many families in the NICU worry when we give their infants opioids. They're so scared we're going to cause their children to be addicted, but these are babies that are getting major surgery or having to undergo invasive testing. So the pain medications are needed, and we're in the hospital. We're monitoring them. But even knowing that makes families really nervous.
I just wish there were more evidence about how we use pain medication and guidelines around it so we could share with families, especially when we're prescribing these medications in our communities.
Well, at least this podcast will offer us all some relief on this topic. To help pediatricians get past some pain points on treating pain, the AAP has issued the first ever clinical practice guideline on opiate prescribing for acute pain management in children and adolescents in outpatient settings. It is accompanied by a technical report, evidence for the use of opioid medication for pediatric acute pain in the outpatient setting.
I feel better already, but that's an ambitious undertaking. Who can help us understand it all?
We can start with lead author Dr. Scott Hadland, the adolescent and addiction medicine specialist who serves as chief of adolescent and young adult medicine at Mass General for Children and Harvard Medical School. It's his third time on this podcast, and today he's bringing along Dr. Rita Agarwal.
Dr. Rita Agarwal is a clinical professor in the Department of Anesthesia at Stanford and Lucile Packard Children's Hospital. She's past chair for the AAP section on anesthesiology and pain management and past president and co-founder of the Society of Pediatric Pain Management. Scott, Rita, welcome.
Thanks for having us.
Thanks for having us. Yeah, excited to be here.
We're excited to have you. Let's start with Scott. Scott, can you talk about the need for this guidance? What are pediatricians' concerns about treating pain in children and adolescents?
Well, one of the reasons that I was so excited to be a part of this clinical practice guideline writing committee with Dr. Agarwal is that she has been really formative in helping to make sure that kids get their pain treated effectively and has been a huge advocate within the American Academy of Pediatrics in support of safe and effective opioid prescribing. And so Dr. Agarwal really laid the groundwork for this with one of her colleagues, Dr. Rita Brown, who together really wanted to encourage the Academy to have some guidance around this. What Dr. Agarwal and what I have seen is that many pediatricians have cut back on their opioid prescribing for all of the reasons that you mentioned at the beginning of this podcast. And although we definitely want to be reducing inappropriate opioid prescribing, the big decreases that we've seen over the last decade in pediatricians prescribing opioids probably also means that some children and teenagers who needed effective pain treatment with an opioid didn't get it. And so this guideline is really in place to help pediatricians understand that opioids can and should be used. They're a mainstay of medical practice, but they don't always need to be used. And when we do use them, there are ways for us to do so safely. That's what this guideline is all about.
So this is one of the rare occasions where a clinical practice guideline starts with a greeting Rita, what was the process for writing this?
So many steps backwards. We were very keen to have a very representative group of authors to work on this. And it included, obviously, Dr. Hadland from the addiction world, myself from the pain world. There was another colleague of mine from the Society for Pediatric Anesthesia, who's also an AAP member who specializes in chronic pain in children. We had members from the emergency room, hospitalists, surgeons, very wide variety of people. We also really wanted to have the parent or patient voice represented. And we were able to recruit a mom named Beth, who was very interested in being part of this process, but also somewhat leery, to be perfectly honest, because she wasn't sure what her role was going to be, whether she was just going to be kind of a voice that was going to be ignored, or it was going to be more like, oh yeah, we included a family member, but they didn't really have any input into it. And so this was one way to really allow her, and we all, and I think Scott will agree, and I think the other members of the subcommittee will agree, her voice was incredibly valuable. She really brought things to the forefront that we would not have thought about before, even with all of our wide range of experiences. And so we really wanted that to be represented in this clinical practice guideline. And so that's what led to the idea of having her write the greeting, because she couldn't really write the KASs or the recommendations as much, but allowing her to write the greeting about, her feelings and the process and why she felt that this was important seemed like a really lovely way to do it. And I know I was blown away at the quality of her writing. It was so good. It was so good.
Rita, you heard us talking about some of the painful conditions we treat. Where do we start when we think acetaminophen and nonsteroidals may not provide adequate relief?
So one of the things that the CPG really strongly pushes is that to always be thinking about pain as a multimodal process, as a multidisciplinary approach. So we start with acetaminophen and nonsteroidals where they're not contraindicated. And then if that's clearly not enough, or we anticipate it's not, you're having surgery, you've broken a limb, you have a big laceration, you have some other thing that's going to cause significant pain, and you will be going home with that significant pain. Then the idea is, what else should we be using? And the thought is, we should be using opioids when they're indicated. We should not be scared of sending patients home on them as long as it's done appropriately. But we should be using the smallest dose that we think the patient needs and for the shortest period of time, with the idea that if they continue to need opioids after 3 to 5 days, they probably deserve a reevaluation or a reassessment, whether in person or virtually or by phone call or something along those lines. So the goal is start with the least harmful medications, add to it what you need to add to it, but use as little as you can for as short of a period as you can, based on what the process is.
And you also in the report mention medications not to use, like tramadol and codeine. Scott, can you tell us why we should avoid prescribing these?
I think often pediatricians feel a little bit more comfortable prescribing medications like codeine or tramadol, which are, in the case of codeine, a lower potency opioid. In the case of tramadol, it's not a full opioid agonist. And so that fills pediatricians, I think, sometimes with a sense of comfort. The truth is that the U.S. Food and Drug Administration has actually placed a series of contraindications and warnings pertaining to these medications, especially when they're used in children. And often when they're used in adolescents, they're actually associated with risk of breathing compromise and risk of sudden death. And this is related to the extent to which they're metabolized and also the extent to which somebody may have pre-existing lung disease or an airway that can be more easily compromised. And so these are really medications that in this guideline, we encourage pediatricians to really be staying away from.
I worry a lot about drug interactions, especially when it comes to narcotic pain medications. Rita, are there specific combinations of meds or meds and conditions that should raise red flags for us?
Well, definitely. So, starting with conditions, any condition that's going to have a significant impact on respiratory function, obstructive sleep apnea, underlying respiratory conditions like asthma, cystic fibrosis. I mean, there's a lot of things that can cause respiratory depression, neurologic conditions that can lead to altered control of respiratory function. Those conditions we should be very concerned about when we're prescribing an opioid to them. When it comes to other drugs, really what we're looking at is other sedative drugs. So anything else that can cause sedation. Most commonly, it's things like benzodiazepines, but it's not entirely those. It could be gabapentinoids. It could be even things like Benadryl, diphenhydramine. Those things can all cause sedation, and of course, so can opioids. So we really need to be cognizant of the sedative effects because, of course, the most serious side effect with an opioid is respiratory depression and things as a result of respiratory depression, such as, not breathing, stopping breathing, inadequate breathing, and ultimately death. So really the interactions that I think physicians and others who prescribe pain medications need to be the most concerned about are those that will also cause respiratory changes.
And Scott, you've talked with us on this podcast about the importance of having naloxone on hand to reverse overdoses. Can you tell us how that practice fits in with prescribing opioids in the outpatient setting?
Right. This is a key headline recommendation that we made in this statement, that every opioid prescription that a pediatrician writes should be accompanied by a prescription for naloxone. Naloxone is the overdose reversal agent that, as you said, can save a life within minutes. And that prescription for naloxone isn't just for the child who's getting that opioid prescription, but there might be other toddlers in the home, for example, that might get into the medication, or other family members that might get into the medication. And we live in a time in which opioid-related overdoses are a leading cause of death in children, in adolescents across the United States. Interestingly, when we dived into the data, there actually weren't a ton of data available to help guide this clinical question. So the expert panel did what an expert panel needs to do sometimes, and that is put their heads together and make a recommendation, even in the absence of data. We felt very strongly that even despite a lack of data on this topic, because more studies are certainly needed, the urgency of our public health crisis, whereby young people are dying at unprecedented rates, really called for us to be making this recommendation. I guess the other thing I would add is that pediatricians can certainly prescribe naloxone, and when they do, it's typically covered by insurance with either no or a small copay. But you can also refer families to pick up the medication, naloxone, over the counter, although it's more expensive when they do that. It's typically right now $45 for a pack of 2 naloxone sprays. And then many community organizations also hand it out for free. So there are lots of different ways that families can get it. But we really think that a pediatrician prescribing it at the same time that they prescribe an opioid allows them to pick up both those medications at the same time.
And if you have naloxone on hand, then how do you know when someone is experiencing an overdose? What are the signs and symptoms?
So that is actually also one of the key action statements, is to review with the families before they go home with their prescription what the signs and symptoms are of overdose. And it includes things like being unresponsive, slowing of breathing or irregular breathing patterns. If you see blue around the lips or fingertips, slurring speech if they're awake enough that they're not completely unresponsive. Of course, not breathing, irregular heart rate, or asystole. So we do recommend reviewing signs and symptoms of overdose. And again, it's not, as Scott has mentioned, not just for the patient for whom this has been prescribed, but for anyone within that family or anyone who has access to medications within that family's home. This needs to be reviewed so that if someone were to inadvertently take an overdose or, accidentally get into the medications if they're a toddler, families will recognize it and know to treat it. And I wanted to if it's okay, I really wanted to reemphasize what Dr. Hadland said about naloxone and the decision that we made very intentionally to say, everybody should get it. So there is evidence, and the recommendations from other organizations are that if you're on opioids plus another sedative medication such as benzodiazepines, you should get prescribed naloxone. But we as a committee felt like, why do we have to wait for another sedative medication? The harm is very minimal in sending someone home on naloxone. The benefit is literally life-saving. So we felt as a committee we should very strongly recommend that.
And Scott, you've talked to us before about diversion and misuse of opioid medications. These remain a major concern. Are there things prescribers or parents should be doing to decrease misuse of opioid medications?
There are absolutely things that parents can do, and pediatricians should be talking to parents about what those steps are. I'll get to those in a second. Before I get into that, I think it's really important, and the guidelines really review this, that problems resulting from an opioid prescription are relatively rare. And I think that's important to know, an important reassurance both for pediatricians who are listening, but also to parents and families to know that the vast majority of the time when we prescribe an opioid medication, it does not result in diversion, in non-medical use, in addiction, in overdose. But of course, there are things that we can do to minimize risk, right? And so this is what pediatricians need to be doing. So the guidelines will say that we should be using the lowest effective dose needed of an opioid to control a young person's pain. We should be keeping the duration of an opioid prescription to the minimal amount of time needed. Usually this is 5 days or fewer. In fact, in many cases, just a couple days is all that's needed. But then pediatricians should also be talking to families about other steps that they can take. Keeping medications locked up, directly administering the medication, a parent directly administering the medication to their child so that they know what's in that pill bottle and how much their child is taking. And then also talking to parents about what to do with the medication when the pain is gone. So if there are pills left over, what parents can do with those pills. And so the guideline recommends that pediatricians partner with parents to develop a plan. Some things that they might do include locating medication drop boxes either at the hospital that a patient is being seen at. Those are quite common in hospitals, or at a pharmacy in the community. Often pharmacies will have medication drop boxes. Police stations often have medication drop boxes. And so pediatricians can partner with families to help figure out where those extra medications can go when the pain is gone.
Rita, I've heard from pain specialists that efforts to stem opioid misuse are making it harder for some patients to get opioid pain relievers when they really need them. How should we as pediatricians walk that tightrope?
So I think this goes to the heart of what the CPG was about. Again, I'm a pain specialist, not an addiction specialist. And so in all the work that I've done, the goal is to get adequate pain relief without increasing the risk of addiction. The bottom line is, again, we start with the basics. We start with the acetaminophen and the nonsteroidals. But if they're clearly not going to be adequate, then we start with the low doses of opioids. And typically, it doesn't matter what you use, but we often, with pediatrics, are using oxycodone because it comes as a separate, liquid and a tablet form. And it's easier to titrate and also titrate the ibuprofen and Tylenol separately. It is really important. And this is actually something we heard very loudly and clearly from our family representative, that having patients who are on stable doses of opioids who are doing really well with them, and then because of the previous set of CDC guidelines and because of the sudden fear around the use of opioids, suddenly they're cut off and now their kids are miserable and not able to get adequate pain relief. We need to do our due diligence. We need to really look at what is the cause of this pain and how significant do we think it is, and is it reasonable to not give opioids in this patient population? We also need to be, talking about diversity and equity, and part of the goal with doing a set of CPGs is that the hope is that they can be applied uniformly to all patients from all backgrounds and all ethnicities and races, and not this patient, but not that patient. So again, I think a lot of it comes down to continued education, continued advocacy, that, pain is bad. Pain is not benign, and not giving a patient adequate pain medication is not necessarily the least harmful thing we do. I mean, we as physicians are taught first do no harm. And I think some physicians feel like, well, if I don't give an opioid, then maybe I can avoid the harm that could come from prescribing an opioid. Whereas we all know that if you're not treating pain and they need an opioid for that pain, that is causing harm on multiple levels.
Rita, I can't think of many clinical practice guidelines in recent memory that have been more sorely needed. And I imagine that our listeners are going to want to read the whole guideline and the technical report. But before they do you have any big takeaways to share?
So for me, one of the big take-home messages of this guideline is that we can treat pain safely. We should treat pain safely. We can prescribe opioids. We just have to be very thoughtful about how we prescribe these medications, and also, make sure that patients are being closely monitored afterwards.
And Scott, what would you add to all that?
The angle I would put on it as somebody who treats pediatric addiction is that, yes, opioids are effective. We should be prescribing them. And also, yes, there is a small amount of risk that comes with an opioid prescription, risk for addiction, risk for overdose. But that risk is low, and that risk can be very carefully and thoughtfully managed by pediatricians. And this guideline is here to help you do that.
Dr. Scott Hadland and Rita Agarwal, thank you so much for talking with us today.
Thanks so much for having us.
Thank you so much for inviting us to be on the show.
To read the Clinical Practice Guideline, Opioid Prescribing for Acute Pain Management in Children and Adolescents in Outpatient Settings, and the accompanying technical report, go to aap.org/podcast.
Coming up, we'll look at how disabilities in parents affect access to care for their kids. So much of the care we provide as pediatricians is to prevent disease. We monitor the growth and development of children so that if something isn't going right, we can intervene early.
I think we as pediatricians take this to heart, but I cannot tell you, David, how much time I spend in the newborn nursery persuading families to engage with a primary care provider within 1 to 3 days of discharge from the hospital. Sometimes they're so confused by this concept when their baby is healthy.
I know. The first 2 years of life for a baby mean a ton of pediatric visits, and not all families realize that or why they're important. To make sure they get things like immunizations, but also to ensure they get appropriate developmental screens.
As someone who has an infant now, scheduling and making all those visits is time-consuming and, hard. And I understand the importance of them. So I can imagine how hard it can be for families to engage that much, especially when they face other barriers to accessing the healthcare system.
That is what makes reviewing a new paper in pediatrics entitled Maternal Disability and Early Child Preventative Care so important. Here to discuss is first author Dr. Hilary Brown.
Dr. Brown has a PhD in epidemiology and biostatistics and is an associate professor at the University of Toronto in the Department of Health and Society with a particular focus on disabilities, chronic disease, and maternal and child health. Dr. Brown, welcome to the show.
Thanks for having me.
Dr. Brown, you're in Canada, but here in the United States, accessing medical care can be challenging for any pregnant woman, especially for those with intellectual and developmental disabilities. What is it like there?
Well, we do have a universal healthcare system here in Canada, which means that all of our required medical care, including prenatal care as well as child-related healthcare, is delivered at no direct cost to residents. So theoretically, cost is not a barrier to care, but as we saw in this paper, there could be other barriers for families who experience marginalization and other structural barriers.
And what made you curious about how accessing prenatal care might spill over to accessing pediatric care?
Right. Well, we had done some research showing that people with disabilities received prenatal care later in pregnancy and received fewer than the recommended number of visits. And that was particularly the case for prospective parents with intellectual and developmental disabilities. And so that made us wonder if the same barriers that affected them during pregnancy could also impact the access of their young children to preventative care. So we know that people with disabilities experience a number of barriers barriers to care, including inaccessible physical spaces, transportation barriers, and sometimes even ableist or negative attitudes from care providers. And so we were curious if those same sorts of issues might impact the healthcare access of their children.
In doing this research, how did you identify mothers with disabilities and then track their visits for their children?
Right. So we used health administrative data from ICES, which is the Institute for Clinical Evaluative Sciences that collects health administrative data on all residents in the province. We used healthcare records to try to identify disabilities. So a disability was deemed present if someone had a diagnosis related to a physical disability, so things like cerebral palsy or spinal cord injuries, a sensory disability, so hearing or vision impairments, or an intellectual or developmental disability, so things like autism or fetal alcohol spectrum disorder. If they had any diagnoses related to those conditions in their healthcare records over time, then we consider them to have a disability. I will say that ideally it would be great to have self-reported disability status information. But in healthcare records, I think probably similar to the states, we're often reliant on diagnoses as opposed to self-reported equity-related data.
And what did you find? Were these mothers able to access appropriate pediatric care for their infants after birth?
So we did see some different patterns depending on the type of disability that the parent had. So mothers with physical or sensory disabilities, for example, their children received preventative healthcare visits as well as routine immunizations at about the same rate as children of mothers without disabilities. But for children of mothers with intellectual or developmental disabilities in particular, there were some fairly significant disparities in those outcomes that we observed.
Can you describe a little bit about what you saw with those intellectual and developmental disabilities and how care was different?
Mm-hmm. So for young children of mothers with intellectual or developmental disabilities, they were less likely to receive the recommended number of preventative care visits by 24 months of age. So in Ontario, it's recommended that kids receive about 6 visits by that age. And children of mothers with intellectual or developmental disabilities were less likely to receive those visits. They were also less likely to receive the number of routine immunizations that are recommended. So again, it's recommended that there are about 10 immunizations by 24 months of age. And we saw that those were less common in those families. We did look at a number of specific outcomes. So for example, in Canada, there's an 18-month enhanced developmental assessment that's recommended for all children. That was also received less frequently in these families. And likewise, specific immunizations like MMR vaccines, which we all know are extremely important, were less likely to be received as well.
This is a little outside the scope of the study itself, but do you have any thoughts on how pediatricians can better support these families when they wish to engage in care?
I think there are a number of practical things that could be done. Of course, with health administrative data, we weren't able to look directly at any of these things, but we do qualitative research in this space as well. And that also informs some of the recommendations that we make. So really practical things like appointment reminders, transportation vouchers, things that address some of the cognitive or kind of socioeconomic challenges that these parents have. So that's on the practical side of things. But I think more importantly is the importance of building a trusting relationship with these families. For parents with intellectual and developmental disabilities in particular, often they have an important history of trauma, often negative experiences with the healthcare system. Many of them have child protective services involvement at disproportionate rates to the general population, even in the absence of evidence of neglect. And so there can be some real fears among these parents about engaging with the formal healthcare system. So So from my perspective, I think one of the most important things that a healthcare provider could do is to take the time to really get to know these families, build that trusting relationship, ensure that there's some continuity of care in terms of those reminders and follow-up and those little extra things that can be done to really make these families feel supported. We definitely hear from parents that those pieces are important. And then finally, I would maybe add, I think oftentimes we hear from pediatricians and healthcare providers that when they think about disability, they're often thinking about that in relation to their pediatric patients, and they're not necessarily thinking about it in relation to the parent's disability status. So I think education for healthcare providers about the unique needs of adults with disabilities, so those parents and what they might need to make healthcare more accessible for them, would be really important as well.
Wow, those are all great things for pediatricians to think about. And do you have any last takeaways for our listeners before they go and read your paper?
Absolutely. I think the main message that we want to come across with this paper is that, the importance of setting up a healthcare system that's supportive of these families and really draws on their strengths and provides the resources that they need to really be able to access the healthcare system more easily. So we did identify some disparities that tells us, something could be done better. And we hope that those efforts are directed at system level changes and supports that can make access more easy for these families.
Well, we certainly hope so as well. And Dr. Hilary Brown, thank you so much for joining us today.
Thank you.
To read the paper, Maternal Disability and Early Child Preventative Care, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, this doesn't start positive or enlightening, but stay with me. As you know, Hurricane Helene swept through the western part of North Carolina and destroyed some areas that I and our whole family hold dear. But what is positive or enlightening has been the incredible outpouring of support. I've had an opportunity to be a participant in some of those efforts and shepherding efforts from our hospital, in calling practices on behalf of the Medical Society and making sure that they have what they need to get up and running, and just watching everybody pull together. Just when you think that we can't get it together as a society, when something like this happens, you realize so many people, first response for them is, how can I help people I don't know in a place that I don't live? And it's profoundly inspiring.
I love that. I love that most people really do want to help. And to try to help make this positive too, I'll talk about my baby because I think a lot of our listeners really like babies.
We all love a baby.
She's just over 9 months, so she has a little bit of stranger danger that's been bubbling and brewing. But the fun thing for that about me is I feel like now how much she really loves me. And the recognition that, oh, it's me, this is the person I want to be with is actually it's hard, right? Because she doesn't want to go to other people very easily, right. But it's also really sweet and how much they love you and connect with you and want to be with you at this time. So that's really nice.
Very tight hugs. But here's the good news for you, Joanna. I just got a very tight hug from my nearly 25-year-old daughter. So they don't go away. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook, Instagram, and YouTube at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at ways to encourage parents to read to their kids.
We'll talk to Dr. Perry Klass about a new policy statement on early literacy. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.